They are devices that we use all day, every day, blood gas machines. In this tutorial, I'm going to talk about how the blood gas machine measures the pH and how it measures the partial pressure of CO2. I think it's something that you need to understand. I'm also going to briefly mention how you interact with the blood gas machine, how you do things correctly. Fundamentals of Anesthesiology and Critical Care with me, Pat Nelligan. Monitoring gases and vapors. This tutorial will look at blood gas monitoring of carbon dioxide and pH. We're going to look at blood gas machines and how they work and how to troubleshoot them. So if you find that the technical stuff at the beginning is too much for you, just scroll on the video towards the end because there's some very important material covered. In the previous tutorials, we talked about end-tidal CO2, capnometry, then we looked at capnography and all the reasons why the capnograph may be abnormal. In this particular tutorial, we're going to try and explain how the blood gas machine measures both hydrogen ions and carbon dioxide. It's a very similar process, it's not identical, and it's worth knowing about. And then I'm going to take you through some tips and tricks about blood gas sampling. Let's start with how blood gas machines work. And we're going to have to start with some electrical basics. Electrodes are electrochemical devices that turn changes in chemical charge into electrical charge for measurement. This is based on the concept of the Nernst equation. Electricity is the flow of electrons from one point using a conducting substance to another point. They flow from a negative pole where there is a surplus of electrons, that's the anode, to the positive pole where there is a deficiency of electrons, cathode. So remember, electrons have a negative charge. The flow of electrons is associated with work, so that's how we get light generation or heat generation, etc. The movement of electrons from anode to cathode can be seen as a pump. The force that is responsible for pumping is the potential, the electromotive force, and that is determined by the difference in electron concentration between the two poles. The greater the concentration gap, the greater the potential. The potential difference is quantified as voltage, so the unit is a volt. A voltmeter is an instrument that measures voltage or potential difference between 2 points. A potentiometer is a voltage measuring instrument that compares unknown voltage to a known reference. In the blood gas machine, we're talking about potentiometers for hydrogen ions and CO2. The devices that we use to measure blood gases were developed between the 1920s and the 1950s, and they are based on the concept known as electrochemical cell systems. Since the beginning, the electrochemical cell system has been called by the singular term electrode, so I'm going to use that terminology. In blood gas electrodes, there are glass or metal electrode terminals. A pair is known as a cell, and individual components are half cells. Each electrode consists of a working half cell where chemical analysis takes place and the reference half cell, which is a standardized compartment against which the electrochemical charge is compared so that measurement can take place. In each of the half cells is a strip of metal that is silver wire coated with chloride, and this is immersed in a salt solution, usually potassium chloride, which is in chemical and electrical equilibrium. And this is the setup. We have 2 silver chloride wires immersed in a potassium chloride solution. The reference electrode must be kept at a rigid electrical potential, so the system is saturated with potassium chloride about 3 molar, so the electrical potential never changes. The glass electrode is embedded in a dilute potassium chloride solution. When a sample is injected into the system, there is an increase in hydrogen ion activity outside the glass electrode. Hydrogen ions adsorb into the surface of the glass electrode because they stick to negative sites on the outer glass surface. Consequently, the outer surface becomes more positively charged. The two surfaces of the same piece of glass have different amounts of positive charge. there is a voltage difference across the glass, a membrane potential between the sample and the inner solution. That voltage difference across the internal buffer solution causes electron transfer to the silver chloride wire, releasing a minuscule amount of chloride, resulting in a small change in the potential measured as potential difference by the potentiometer. And that is proportional to the hydrogen ion activity. There is no voltage charge. The potentiometer just listens to voltage change. The electrochemical theory behind this is the Nernst equation that relates electrical voltage or potential to changes in chemical concentration. So now that you know the basic concept behind this, we can look at the pH electrode. The first component is the potentiometer that measures pH. To this is connected two electrodes. The first is a pH sensing glass electrode and the other is a pH independent reference electrode. So there is a reference half. Both electrodes are connected to the voltmeter. The reference electrode is in a 3 molar potassium chloride solution with the silver chloride wire inserted in it, but it does not contact the blood. It is purely a salt bridge. The pH electrode contains a weak potassium chloride-based buffer solution that also contains a silver chloride wire. There is a potential difference between the two electrodes, and that is proportional to the hydrogen ion activity of the sample. The whole system is connected by a sample container. There are two half cells in contact with one another, and the measuring half is on one side, the glass electrode, and the reference half cell is on the other. The reference electrode has a charge that never changes, so if there is a change in potential or electrical charge in the glass electrode, it is measured as a change in the potential difference between the measuring and the reference electrode, and that is used to calculate pH. When blood is injected into the sample chamber, that blood will have a different hydrogen ion activity than the buffer solution. The hydrogen ions interact with the outer surface of the glass. Remember, this is a glass electrode. It has a thin hydrated gel layer on each side. On the inside, there is an internal buffer fluid with a fixed pH of 7. On the outside, the sample pH will vary. So when the sample is injected, the glass hydrogen ion selective membrane, the difference in pH activity between the outer and inner gel layers creates a membrane potential. That potential difference across the glass is measured by the potentiometer, and it's converted into the hydrogen ion activity or concentration or pH. And that's how the hydrogen electrode works. The carbon dioxide electrode that is in all blood gas machines is a modification of the pH electrode, and it was developed by John Severinghaus, an American, in the 1950s. And it looks just like the glass electrode for measuring pH with a couple of small modifications. The major modification in the CO2 electrode was this ion impermeable membrane that separates the sample container from the pH electrode. This membrane is made of Teflon or silicon. Water and electrolytes can pass through it, but it's fully permeable to carbon dioxide. And on the other side of this membrane is a little bath of sodium bicarbonate and saline. When blood is injected into the sample container, carbon dioxide diffuses into the space around the measuring electrode, and it binds with water to form hydrogen ions and bicarbonate. The hydrogen ions interact with the glass electrode, generating an electrical potential that is measured in comparison with the reference electrode, and that is used to calculate the hydrogen ion activity between the two electrodes, and a calibration curve is used to calculate the PCO2. Now that I've explained all three electrodes, the oxygen electrode, that's the Clark electrode that I discussed in a previous tutorial, and the glass electrode that's used for CO2 and hydrogen ion activity in this tutorial, let's see how these are utilized within the blood gas machine. This is a very simple schematic of early blood gas machines. Note that the temperature within the machine is controlled at 37 degrees Celsius. Blood is injected into the sample port and then it is exposed to the various electrodes. Those electrodes are the hydrogen electrode, the oxygen electrode, and the carbon dioxide electrode. Note that there is a common reference electrode for CO2 and hydrogen ions. When the measurement has been completed, the sample is then flushed out of the system. Modern blood gas machines incorporate these technologies but reduce the size and increase the complexity by limiting the need for relentless cleaning and calibration by technicians. This is the schematic of the inside of the GEM 5000, and hopefully after these tutorials it will make more sense to you. Just to orientate you, the blood sample is injected here and it travels around the system where it engages with the sample card and then it is pumped out through the waste bag. The reference solution is here. Focusing in, this is the sensor card within the machine that contains a Clark electrode for oxygen and the pH and CO2 electrodes, plus the reference electrode, just like the earlier generations of blood gas machines. Modern machines also measure common electrolytes, lactate and glucose. It's worth noting that the blood sample is actually split here for whole blood to be diverted to the blood gas and electrolyte component and blood that undergoes lysing for co-oximetry. The lysing solution is on the top left. And if you ever wonder why the rinse cycle seems so long, look at all the work that the machine has to do. Now let's move on and discuss blood gas sampling. I guarantee you will find this part of the tutorial so much easier. Blood gases can be taken from venous or arterial components of the circulation. In general, the closer that the venous blood gas is sampled to the main pulmonary artery, the better. So a venous gas from a pulmonary artery catheter is better than a central venous catheter in the right atrium versus a femoral central venous catheter versus a peripheral stab. And the reason for this is blood mixing. Blood is fully mixed in the pulmonary artery. That's why it's called a mixed venous blood gas. There are problems with blood gas sampling. The first one is that the sample itself will clot almost immediately after you take it, so the sample needs to be heparinized. I'll get back to that in a second. The other thing is that if you're not careful about how you take the sample may be damaged and the red blood cells may hemolyze, leading to the measurement of intracellular content in extracellular fluid. So you will have overreading of potassium, hydrogen ions, CO2, and underreading of sodium, calcium, and PO2. Air bubbles will overread the PO2 and the pH and the saturation and underread the PCO2. And if you shake a sample that contains loads of air bubbles, all of this will be so much worse. So you need to make sure that when you take that sample, you push out any air that may be still in the syringe and close the syringe very carefully. There's usually a little cap in the bag. Before drawing the sample, if taken through a line, draw back fresh blood from the arterial or the central venous catheter so that whole blood is collected. You do not want any dilution with the flushing solution. In general, if at all possible, please use a blood gas syringe. There are specific syringes that are provided in all hospitals that are made for collecting blood gas samples. You should not be trying to make up a syringe yourself using heparin. It's a total mess. That syringe has been heparinized to prevent clotting. The inner lining of modern blood gas syringes is spray coated with lithium or calcium balanced heparin. Heparin is strongly anionic and it binds calcium. That will reduce the ionized calcium. So the additional bit of calcium that's put in there with the heparin balances the results so that you get correct calcium measurement. Lithium is sometimes used to avoid problems with sodium measurement. Heparin is usually USB as heparin sodium. This is the syringe that is available today in my hospital. It may be different next week. And you can see there's a specific syringe with a little cap that you screw on the top of it once the sample has been taken. And you can see that in 3 mils, there is 80 units of calcium heparin. Liquid heparin can cause an array of misreads in the system, particularly if the whole thing has been assembled by an amateur. And so I think that the dry heparin spray that's in the modern blood gas syringe is one of the great advances in our practice, believe it or not, in the 21st century. By dry coating the syringe, the proportion of heparin that is in the sample is always the same, no matter how big the sample is. Now, these syringes are 3 mils, and they contain 80 units in the 3 mils, but that works out at 26.6 units per mil. And nobody draws 3 mils. If only 1 mil is drawn, that will contain 26.6 international units per mil of blood. If 3 mils is drawn, 26.6 international units is in each mil of blood, so it doesn't vary. But the thing is, because it has been dry sprayed, you need to make sure that that sample is mixed properly, that all of that blood comes in contact with the wall. So as soon as that sample is drawn, microclots will appear, and that can cause a horrendous heterogeneous sample, overreading the potassium, underreading the sodium. So what you need to do as soon as you take it is to agitate that syringe by inverting it, turning it upside down about 5 to 10 times, and then rolling it between your hands 5 to 10 times to mix in that dry heparin. The temperature is also really important because temperature affects blood gas analysis. The machines by default measure at 37 degrees, but gas is more soluble in colder blood. And remember that as you heat up water and blood, it becomes more apparently acidic. The hydrogen ion activity increases, but of course it's still chemically neutral. So for every 1 degree Celsius fall in body temperature, the PaO2 drops by 7.5%, the PCO2 drops by 4.5%, but the pH goes up by 0.15 units because water dissociation reduces. For every 1 degree Celsius rise in body temperature, the PaO2 goes up by 7.5%, warm blood holds less dissolved gas. The CO2 rises by 4.5%, and the pH goes down by 0.015 units because of water dissociation. The blood gas machine will measure that sample at 37 degrees and provides an uncorrected or standard measurement, and that's known as alpha stat. If the patient's temperature is entered, the machine uses a set of algorithms to provide a temperature-corrected set of values. That's the pH stat measurement. Most of the time, in most situations, you should use the uncorrected measurement for blood gas analysis. Now, there are arguments out there for alpha stat versus pH stat. Most clinicians cannot interpret pH stat blood gases, and this may lead to mistakes. Hypothermia is associated with reduced metabolism, and apparent respiratory alkalosis is misleading as the anomaly is merely normal physical chemistry. However, pH stat clinicians believe that by administering CO2 during cardiopulmonary bypass or hypothermia will increase cerebral blood flow and lead to better neurological outcomes in children. That is a highly specific group of clinicians who work on a very little island of clinical care. In the ICU, in the operating room, or wherever you may draw a blood gas, the uncorrected blood gas measurement should be used, the alpha stat. Remember also that blood is alive. It contains red cells, white cells, and platelets. And by delaying the processing for more than 15 minutes, there may be an increase in hydrogen ion activity, a reduction in the PO2, and a rise in the PCO2, although the CO2 rises less than you would expect for the amount of oxygen consumed due to glycolysis. Remember, red blood cells don't contain mitochondria, so you don't have a lot of CO2 produced by the red blood cells, but some is produced by white cells and by buffering. You may also see a rise in the potassium and the lactate and a reduction in the sodium. So in general, when you take a blood gas, try and get it to the machine within 15 minutes. If not, you can consider placing it in ice. That will slow metabolism. The machine, regardless, will rewarm that blood sample to 37 degrees Celsius. Also, be aware where there is very, very high white cell count in severe sepsis or more likely in patients with leukemia. That will have an impact on blood gas analysis because those white cells will consume oxygen at a rapid rate, reducing the PO2 and increasing the PCO2. Be a little bit careful of the sample you've been shown and make sure that you know what you're looking at. Is it a venous blood gas or an arterial blood gas? You can sometimes be confused about which sample you've been shown. In my view, the most reliable indicator overall is actually the PO2. The normal PO2 on a venous blood gas is about 40 millimeters of mercury or 5.3 kilopascals. The saturation rarely exceeds 75%, but it can go up to 80%, for example, in severe sepsis. So generally, if you're looking at it, look first at the PO2. It's going to be low regardless, and then the saturation. The other measurements on a venous blood gas are not that dramatic. Yes, there's a big difference in the oxygen. The CO2 may be significantly higher on the venous side than the arterial side, particularly if the patient is profoundly hypovolemic. This is sometimes known as the PCO2 gap, but it is not all that dramatic, particularly when measuring in kilopascals. The other samples, such as the lactate, the sodium, the chloride, the calcium, the glucose, there's such a marginal difference between the arterial and the venous side that you can happily use the venous blood gas as a way of evaluating the electrolytes in plasma. Let's review this tutorial. In this tutorial, we looked at monitoring of carbon dioxide and pH in the blood gas, and I explained how blood gas machines work to measure both hydrogen ion activity and CO2. I then went through some of the issues you may encounter when you draw a blood gas, either a venous or arterial sample, what you need to do to make sure it doesn't clot, how quickly you need to put the sample in the machine, and also how to distinguish between a venous and an arterial sample. Next time, we're going to wrap up this section by looking at the variables that you'll see in a blood gas printout but may not understand. They're the hydrogen ions, temperature correction, some of the derived oxygen variables, bicarbonate, total CO2, the base excess in blood and extracellular fluid, the standard bicarbonate, and the anion gap. I'll see you then, and I guarantee you'll learn something.